And good afternoon, everyone. My name is Satish Munigala. I'm the PhD student at St. Louis University Center for Outcomes Research. My topic is looking at prior history of pancreatitis, accelerating the development of pancreatic cancer. So we have seen a lot of good talks about the cancer. I'm looking at pancreatic cancer. So pancreatic cancer is the first leading cause of cancer mortality in the United States. We have seen colorectal cancer and the prostate cancer, and pancreatic cancer is next in the line. It's almost like fourth leading cause of cancer mortality in the United States. As you can see, in 2017, there were about 53,000 cases, new diagnosis, almost like 80% deaths, like about 43,000 deaths in the 2017. So it is estimated that by 2025, it is going to be the second leading cause of cancer deaths in the United States. So the 1-year survival rate is about 28%, and if you see the 5-year survival rate is almost dismal, less than 10%. So the recent findings from the mouse model shows that acute pancreatitis, which is AP, promoted cancer carcinogenesis by inducing the acinar to ductal metaplasia with the oncogenic KRAS mutation. These are one of the mutations which cause the cancer. And there is also some studies which specified about the role of inflammation in pancreatic cancer through the chronic inflammation. So my goal is to look at this, whether the inflammatory changes either related to acute pancreatitis or pancreatic cancer would result in earlier age of diagnosis of pancreatic cancer. So this was looked into the mouse models with the limited research, but there are no studies in the humans. So my aim is to look at that. So we looked at the pancreatic cancer risk after acute or chronic pancreatitis. So I looked at the cohort after 2 years after the diagnosis of pancreatitis. So for this study, I used the VA database. Although I looked at the VA database from the Missouri, it has access to all the national VA patients. So I looked at the national database, which is maintained by the VA system from 1999 to 2015, which is almost about 15 to 17 year follow-up. So for this study, I used the ICD-9 codes for pancreatitis and pancreatic cancer and other diagnosis conditions which I have looked into in the system. So the VA database consists of many subset data sets. It has inpatient and outpatient data sets, and there are other like the VA patients who take care outside the VA system. There are separate database for that. So overall, there were about 34 data sets. So for my study, I pulled the data from the 34 data sets and constructed my own final data set using the ICD codes. So pancreatic cancer is mainly the cancer in the adults. So we have included all patients 18 and above in the VA database. So for my study, I wanted to look at least, since I'm looking at a follow-up study, I wanted to see the minimum have a 2-year follow-up in the system, and they've used the system at least for 2 times. Obviously, if the pancreatic cancer is already present, I have excluded those patients. And overall, like I came up with about 13 million unique records in the system. So the goal for the analysis was looking at the incident rate ratio, comparing the controls and the patients with pancreatitis, and also getting the 95% confidence intervals. So the main hypothesis was looking at the age of onset of pancreatic cancer. So I looked at the median age of pancreatic cancer presentation and the risk factors which are leading to the pancreatic cancer diagnosis. Then finally, I looked at the pancreatitis episodes and the risk of pancreatic cancer. So sometimes pancreatitis can be a single episode, or patients will have recurrent episodes. So we don't know the risk if the patient has a single episode versus recurrent episode. So I also looked at the risk by the number of episodes. So this slide is a little busy. So initially I started with 13 million patients. So after I excluded the patients who have single visit and less than 2-year follow-up, it came down to 11 million or 10 million odd. So after I excluded the patients who are pre-existing pancreatic cancer, then the patients less than 18 years old, I came up with a total population of about 9 million. In that, about 40,000 cases were with acute pancreatitis and rest were the controls. So in that, I have split that group into patients with acute pancreatitis with the history of chronic pancreatitis, which is nothing but the chronic recurrent inflammation, with and without chronic pancreatitis. Similarly, if a patient does not have acute pancreatitis, but he may have a chronic pancreatitis, so that group is split up as well. So the controls are also split up by chronic pancreatitis, with and without. So if you look at, sorry for the slide, but if you look at the patients with acute pancreatitis with a previous history of chronic, the risk is about 0.7%. If acute pancreatitis without, it is about 0.3%. Just chronic pancreatitis is 0.4%, and the controls, which is like the standard risk, is about 0.12% prevalence in the system. So this slide is looking at the predictors for pancreatic cancer. Obviously, the risk is after the 2 years, 2 years after the presentation of pancreatitis. So the risk is high in African American race, the male population, those who are smokers, alcoholics, diabetes mellitus, gallstone disease, and our interest group, which is acute pancreatitis without pre-existing, it is about 2. Patient with pre-existing chronic pancreatitis is much higher, which is 4.7, and those only with pre-existing chronic pancreatitis is 3.4. So this is looking at the multivariate logistic regression using ProgGen mode. So after we look at the univariate risk factors, we put all the factors in the model and get the final data set with the final risk factors. So the main aim was to look at the median age of presentation of pancreatic cancer. So I do have 4 groups. The patients with acute pancreatitis, with the pre-existing chronic pancreatitis, comparing with all the patients with controls. So this is the interesting finding that we were hypothesizing. It was modeled in mouse models looking at acceleration of pancreatic cancer in patients with acute pancreatitis. So there are no human studies. So this is the first hypothesis looking at it. So as you can see, the patients in the control group, the pancreatic cancer median age presentation was 70. The patients with acute pancreatitis cohort, it is about 67. That is 3 years prior to the presentation of the traditional age. And if you throw acute pancreatitis with the pre-existing chronic pancreatitis, it is much lower. It is presenting at the age of 64 compared to 70. And if you only have chronic pancreatitis, it is 66 years. So on an average, patients with pancreatitis are presenting with pancreatic cancer anywhere from 3 to 5 years before the traditional normal patients who come into the system, that is about 70 years. So some of the mentors, when I was presenting this hypothesis during the pre-session, asked me to look at the patients with some of the patients with chronic kidney disease, because this patient group may or may not seek medical attention. They wanted to see a cohort or a control group who also need medical attention. Probably that might have biased it. So I looked at the subset of patients in this control group with the chronic kidney disease, and the patients with chronic kidney disease without any acute or chronic pancreatitis, their age at presentation was 76 years. So if you look at the people who have sought medical attention in the patients without acute or chronic pancreatitis, that is, for example, chronic kidney disease, it was presented at the age of 76. So on an average, about 7 to 8 years older or after the traditional with the acute pancreatitis. So the last aim was to look at the risk of pancreatic cancer by the number of episodes. As you can see, if you have 1 episode, the risk was about 0.25%. And as you see, the number of episodes increases, the risk increases to about 1%. Future analysis, as far as the hypothesis is concerned, we are done with all the analysis for the study. So my other interest looking at the data is looking at new onset diabetes and pancreatic cancer. There is a relationship between chronic pancreatitis, diabetes, and this typo should be pancreatic cancer, and identifying the non-traditional risk factors for pancreatic cancer. So obviously people always start with the risk factor and then look for the risk for the cancer or outcome. And for pancreatic cancer, it is unique that the traditional risk factor would add up to only 30% of the cases of pancreatic cancer. So we do have the database. which is a rich database about 50,000 pancreatic cancer cases. No one in the world has this kind of numbers. So my idea is to look back. I want to do a fishing expedition, which is like a controlled fishing expedition. We do have the data. So there is nothing lost. So what I want to do is start with all the pancreatic cancer cases, look back. I do have like 10 to 15 year follow-up of the patients. So I wanted to look back each and every case. What do they have? Are they presenting with any symptoms that which are missing? Based on the traditional risk factors like diabetes, chronic pancreatitis, age, race. So I wanted to see if there are any other factors which are contributing to it, which we miss it. Learning experience, obviously this is a huge database. So I got few calls from the VA IT that I almost like broke their server. I've got like 15 emails saying that you are pulling a lot of data, and sometimes like each variable is not, I've pulled 13 million records, so each variable is not just 13 million record, each patient comes back to the system like many times, 100 times. So for example, if I have to extract the age, for age, if a patient had like 10 follow-ups, I had like 250 million records for those patients. So extracting huge data was challenging. That is one of the things. And one other satisfaction I have is about validation. So this hypothesis was studied only in the basic mouse models. So now we do have the human study validation for the mouse model hypothesis. So that is satisfying. And this is the unique database. We don't have a cancer follow-up for so many years. So this is one good thing. I'm happy about it, that we have at least like 15 to 17 year follow-up to look at the factors leading to the cancer. For future students, like I think if you are interested in VA database, this is a real gold mine to look at the cancers because of the huge numbers and the duration of follow-up. So you can look at the identifying the risk population and also look into the screening. And I haven't looked into the survival rates for this cohort, so the next step would be to look into the survival rates, whether it has any effect on the survival of pancreatic cancer. Now we identified that acute and chronic pancreatitis are presenting with pancreatic cancer at an earlier age, but we don't know whether it will influence the mortality. So we have seen a lot of screening for colorectal and prostate cancer. So pancreatic cancer is not at that stage. There is no screening, traditional screening for pancreatic cancer. That's because unfortunately the patients who are diagnosed, they are diagnosed at a late stage, and by the time you intervene, it's too late for them. So my idea and the goal, future goal, is to look into the early markers for diagnosing pancreatic cancer, so we can put in a sieve or a filter, so we can target those population or patients to send them for screening. Strengths, it is less expensive, but it is a huge database, so we can get large numbers, rich data source for the follow-up, as I told you before. And we need to know the limitations are like we need to know the data. It is based on ICD codes, but fortunately, ICD codes, you might have errors in them, coding mistakes, but fortunately for cancer, it's not the case because cancer is obvious. People like diagnose the cancer either today or 1 month down the line. So the ICD codes are pretty solid, like sensitivity and specificity are high. And I looked at the VA database, which is restricted to veterans. May not be generalizable, but the hypothesis, what we looked at, we got a validation which was recently published 2 months ago from a total different population from a total different country. So we have a Dutch publication recently published in Gastroenterology, which is a top journal, which validates spot on with what we got. So it is a good satisfaction that the data is validating with a totally different database. And obviously it might take long time, so you need to have experience with the VA dataset. That's the limitation. Future personal goals, I want to apply for grants because of the huge database we have. And my other interest is looking at early markers for pancreatic cancer diagnosis. Oops. I would like to thank my mentor, Dr. Banke Agarwal and Dr. Thomas Burrows. Without them, I wouldn't have completed this project. And thank you, everyone. Can take any questions?
You showed that this pancreatitis upped the risk and that the number of episodes correlated with the risk. But it wasn't clear to me how the length of time between the first episode of pancreatitis and the diagnosis of pancreatic cancer, and what fraction of all patients who have one episode of pancreatitis go on to develop pancreatic cancer. Because if that lead time were considerable and the fraction were high, that might be a group that one could focus screening on. I agree with you. I don't think that screening the whole population for pancreatic cancer is going to happen anytime soon, because the frequency is fairly low in the overall population. But among patients who have an episode of pancreatitis, what's the frequency?
So for my cohort, what I've seen is about 60% of the patient have just
60
have just one episode of acute pancreatitis.
No, I'm talking about the other way. What fraction of pancreatitis patients go on to have pancreatic cancer?
So what
length of time is involved in that?
So that's what we are looking at. Like about 1% of the patients with pancreatitis develop pancreatic cancer, and length of time, it ranges from anywhere from 3 years to 15 years. My data set, I haven't shown the slide here, but I looked at 15-year follow-up once acute pancreatitis is developed, so they are evenly distributed. So
even if you took all the patients who had an episode of pancreatitis in the country,
with or without, what are you?
With pancreatitis,
yes,
and you followed them for
yes.
15 years, you would still only find 1% of that group that would develop pancreatic cancer.
Yes. So, but that 1% is similar to colorectal cancer, colon screening. Patients above 50 years old, the risk is 1%. So our idea is to generate the enriched cohort once you have the acute pancreatitis, to find out who are the patients within the acute pancreatitis who are developing higher risk. So the next step is looking at the enriched cohort. So how I can enrich the cohort so they can be taken up for screening. So 1% is a good number, 1 to 3%. That's what colorectal, all the cancer screenings are. If you have 1%, you take them for screening. So the idea behind it is to enrich the cohort once you develop the percentage, so that you'll find more and more cancers.
Satish, I have a question, because colon cancer and pancreatic cancer are different in
Yes.
terms of carcinogenesis and pathways and early detection and development of cancer on top of a polyp, because it's a different story
Yes.
for
Yes.
pancreatic cancer. So I want to follow on Dr. Harford's questions, because with tumor heterogeneity, you are not sure if this cancer originated on top of pancreatitis or not, right?
Mm-hmm.
So if you followed the patients for a short period of time, and your period here was 2 years, it's not guaranteed that this cancer started on top of pancreatitis, because if the patients have risk for pancreatic cancer, this could be de novo pancreatic cancer without the pancreatitis. How can you be sure that this is a cancer on top of pancreatitis? For colon cancer, it's easier because we can understand and see the cancer on top of a polyp, but it's different for pancreatitis and pancreatic cancer, especially that you don't have the histopathology or the histology of the tumor.
Yeah. So once pancreatic cancer is developed, so you can't differentiate or say that it is due to pancreatitis or it is due to diabetes or something. So these are the traditional risk factors.
Did you review the histopathology reports?
So for my data set, there is no histopathology. It's difficult to look into histopathology for 50,000 cases. So it's based only on the ICD-9 codes. So what we did is, like, we did sensitivity analysis. Once you find out a ICD-9 code, I look up multiple ICD codes for the same patient, whether it is single error captured by error or it is consistently captured throughout the system. So I look up the sensitivity. Once I have a ICD-9 code, I see if the patient has got subsequent ICD code within 2 months, 3 months, like that. So all the cases which we included are the ones which have multiple ICD codes for the patient, and they've got like mortality date of death. So 90%, 95% of the cancers have got mortality within like 6 months to 1 year. So it is obviously indirectly validating that these patients have pancreatic cancer.
But Amr, isn't it the case that all of this could be explained not by pancreatitis causes pancreatic cancer, but that there is a common risk factor for pancreatic cancer and pancreatitis, whether they're occurring in the same histopathological region of the pancreas or not, they overlap in risk factors. You would get this kind of result of a higher frequency based on that common shared risk factor.
So that is the reason we control for traditional risk factors. So the traditional risk factors are diabetes, age, African American race, smoking, alcohol.
And these risk factors are the risk factors for pancreatitis
And
the risk factors
pancreatic
for
cancer. Yes, so we control all for that. Even after controlling, we looked at the cohort of acute pancreatitis, which has a higher risk of pancreatic cancer. So my hypothesis, if you look, we included pancreatic cancer diagnosis only after 2 years after the acute pancreatitis. So it means acute pancreatitis is kind of promoting carcinogenesis after like 2 years. So we have excluded the cases within the 2 years because it's a two-way hypothesis. Pancreatic cancer is like a ductal blockage. There is a tumor, so it blocks the duct. It might lead to inflammation. It might present with acute pancreatitis. So it is a two-way hypothesis. That's the reason we exclude the patients within 2 years of acute pancreatitis to give a benefit of doubt that pancreatic cancer is presenting as acute pancreatitis. So we have excluded that cohort. We have not included at all. So this hypothesis is looking at long-term, medium and long-term risk of pancreatic cancer within the pancreatitis cohort.